I think we have a mixed audience here. So my talk will include some basics and also some, of course, we will cover the details. So I hope there's something interesting for everyone and you will find it interesting and exciting. There are 4 valves, as we know, and 3 of them cause problems in adult patients: the aortic valve, the mitral valve, and the tricuspid valve. So we come on then to another group of patients with functional mitral regurgitation due to ischemic heart disease, coronary artery disease, the functional ischemic mitral regurgitation. So in this group of patients, they have a myocardial infarction, and then the part of the ventricle which has a myocardial infarction is not able to contract. It remodels, and then it pulls the pulmonary muscle and the supporting leaflets apart, and therefore restricts the mitral leaflets, and therefore cause mitral regurgitation as a result. A so-called Carpentier type 3B mitral leaflet motion restriction during systole. And if the coronary disease is more extensive, if they have multi-vessel coronary artery disease, if the pre-vessel coronary artery disease, particularly involving the LAD and also the circumflex and the right coronary arteries, you can get a more uniform dilatation of the left ventricle, similar to what you see in dilated cardiomyopathy. So this is another example, another case. This is a 47-year-old man, and he becomes short of breath on malexertion. He was in CCS class 3, so he had angina as well on malexertion. He had autopnia, bilateral leg swelling. And you can see his LV was very dilated. The ejection fraction was impaired. The LV apex was non-viable. You can see there's even some thrombus here. This part was non-viable on cardiac MRI. And yet moderate functional mitral regurgitation, as you can see there. And this is his angiogram. You can see it's got very extensive coronary disease. His LAD was occluded, very poorly filling. The circumflex was critically stenosed, and his right coronary had significant stenosis at multiple sites. So a question for you: how would you manage this patient? By medical treatment only, or by medical treatment plus PCI, or with CABG, or with CABG plus mitral valve repair or replacement? Okay, that's interesting. So 68% feel you should have optimal medical therapy plus CABG plus a mitral valve repair or replacement. 11% thinks optimal medical therapy plus CABG. 17% thinks optimal medical therapy plus PCI. 4% thinks optimal medical. So this patient was optimized on guideline-directed medical therapy for 1 month. It's important in these patients, even if you're considering surgery, that they are optimized for a period of time on medication for their heart failure. In this case, the patient had aspirin, bisoprolol, Entresto, and spironolactone. And in this case, in this patient with critical coronary disease, there is a balance between how long we manage them on heart failure treatment before we revascularize them, because during this period they are at risk of myocardial infarction and sudden cardiac death. So on balance, we probably shouldn't wait 3 months in patients with critical coronary disease, but a balance of 1 month is probably reasonable to get their heart function in a better shape before going for revascularization. In this patient, because of the severity of the coronary disease, PCI would have been technically very challenging and high risk as well, and bypass surgery would have been technically easier to do, and so he went for bypass surgery, and he had internal memory artery to the LAD, a vein graft to the intermediate, a vein to the OM1, and a vein graft to the PDA. Interestingly, despite the poor LV, his Euro score worked out at 2%. So his risk of surgery was 2%. So the risk of bypass surgery has really improved a lot nowadays due to the better medication and better management, both preoperatively, intraoperatively, and also postoperatively for these patients. So this is his echo 2 years later after his surgery. He is now asymptomatic. His ejection fraction had improved to 35%, and he had no mitral regurgitation. You note that we did not do a mitral repair, and we will go into this in the next few slides. So this patient's mitral regurgitation, this is just to compare his echo before surgery and 2 years later. So his mitral regurgitation improved with just revascularization, and of course with optimal medical treatment, which has to be continued even after surgery. So if we look at the trials to guide us on how best to treat these patients, this is data from the STITCH trial, looking at patients with ischemic heart failure, and you can see that patients like this patient who had ischemic heart failure, their long-term survival is improved significantly if they have CABG in addition to optimal medical therapy. And this is a meta-analysis of all the trials on heart failure, and you can see that the survival is much improved in those who have CABG compared to just those who just have medical therapy. And comparing and the same goes for the hospital admissions for heart failure. You reduce that if you revascularize them by CABG. And if we compare CABG against PCI, the survival is better in this group of patients who have ischemic heart failure because there's a more complete revascularization. And if you compare CABG against the drug-eluting stents, survival is also better in those who have CABG in presence of heart failure, as well as the incidence of myocardial infarction is reduced following CABG compared to PCI, and so is the risk of repeat revascularization. So the evidence for CABG is very strong. There is level 1 evidence to support CABG. So this is another case, case number 4. This is a 81-year-old man, previously a very fit 81-year-old. He was doing his gardening and very active, and then he suddenly became short of breath over a few weeks. He was then short of breath on mild exertion, and he had chest pain on mild exertion. His left ventricle had dilated, not as much as the previous case, but it was dilated. EF was down to 40%. And his mitral regurgitation was severe, a lot worse than the previous case, with an ERO of 0.6. And this is his coronary angiogram. So you can see a tight left main stenosis there, multiple stenosis in the LAD, critical stenosis of the circumflex and diagonal, and his right coronary was occluded. So a question for you, how would you manage this patient? Optimal medical treatment only, or with PCI, or with CABG, or with CABG plus a mitral valve repair, or CABG plus mitral valve replacement? Okay, so we are a bit split here. So 37% thinks CABG plus mitral repair, 24% CABG plus mitral valve replacement. Actually, we're not that split because 60% thinks we should intervene on the mitral valve in addition to CABG. 12% thinks should have CABG. 22% thinks PCI is good. So in this case, we did do CABG and a mitral valve repair, and this is his echo 2 years later. He's asymptomatic. His LV had returned to a normal size with normal function, and he has no mitral regurgitation, and he's back to gardening and doing everything he likes. His quality of life is very good. So he's done very well from revascularization plus mitral valve repair in this case, and importantly, with continuation of his medical treatment. So if we look at the natural history of ischemic mitral regurgitation, we see that patients with even mild degrees of mitral regurgitation have an increased probability of death compared to those who have no mitral regurgitation. And obviously, if they have moderate or severe mitral regurgitation, then they have a significantly increased probability of death, and also an increased risk of heart failure admissions if they have more than mild ischemic mitral regurgitation. And this does not seem to be improved fully with revascularization. As you can see from this study, after CABG, if they have residual moderate mitral regurgitation or even mild mitral regurgitation, then there is an independent predictor of reduced survival at 5 years after CABG. So as in non-ischemic heart failure, the aims of intervention is similar. Firstly, to improve their survival. Secondly, to improve their symptoms and quality of life. And thirdly, to avoid hospital admissions. So the intervention which would improve their heart failure or their survival is the optimal medical treatment. And they also need revascularization for their coronary artery disease and intervention on the mitral valve if it is significant. And for the best outcome in these patients, all of these three conditions must be addressed. But as I mentioned earlier, ischemic mitral regurgitation is a heterogeneous condition because we have different degrees of severity. We have mild, moderate, severe, and very severe, different degrees of mitral leaflet tethering, different degrees of LV size, geometry, function, and viability. So a tailored approach is needed. So first of all, in the last two cases, we have to decide, is an intervention on the mitral valve needed? In the last case, we did intervene on the mitral valve. The earlier case, we just left it alone and just revascularized it. So what determines the need for revascularization? The severity of the mitral regurgitation is one of them. If it is severe or very severe, then some intervention is advisable at the time of revascularization, and also the degree of LV viability. If the mitral regurgitation is moderate in severity and all of the LV is viable, then you could probably not repair the mitral valve. But if the LV was showing large areas of non-viable segments, particularly in the segments supporting the papillary muscles, then the mitral regurgitation is unlikely to improve with just revascularization. And in that case, it is beneficial to repair the mitral valve at the same time. If the mitral regurgitation is mild, then there's no need to intervene on the mitral valve. And then we have to decide on the type of mitral valve intervention, whether we repair the valve or replace the mitral valve. And to help us answer that question, we have to look at firstly the degree of severity. If it's only moderately severe, then usually we do not need to repair it. We can repair it very successfully. But if it is very severe mitral regurgitation and there's severe tethering of the leaflets or severe dilatation of the LV and distortion of its geometry, then in those cases it may be necessary to replace the mitral valve. So in mild mitral regurgitation, optimal medical treatment and revascularization if indicated. Don't forget, not all coronary disease needs revascularization. Some of them, if it's not too severe, can be treated with just medications, and no intervention is needed on the mitral valve. Moderate mitral regurgitation, half of them improve with just revascularization, the other half do not. So in these patients, it depends on the amount of viable LV segments. If all of them is viable, then there's no need to intervene on the mitral valve. But if there's more than 4 non-viable inferior LV wall segments, then intervention of the mitral valve is beneficial. So this is another case. This is a 51-year-old man. He was in NYHA class 3, so that he's short of breath on mild exertion. He had 3 vessel coronary artery disease, moderate mitral regurgitation, and you can see on the cardiac MRI, non-viable inferior LV wall. It is highlighting with gadoliniums. So in this case, he had 4 bypass grafts and a mitral annuloplasty. Because the non-viable segments is the segment supporting the papillary muscle. We can see that very clearly. The papillary muscle is attached to the non-viable segment. So the patient is unlikely to show an improvement in the mitral regurgitation with just revascularization, and intervention on the mitral valve is needed. I think I've given you the answer to this question. But anyway, we can take the poll. How would you manage this patient? Just optimal medical treatment, or with PCI, or with CABG, or with CABG plus a mitral valve repair or replacement? Okay, so the split between repair and replacement. 90% thinks we should either repair or replace it. Yes, it is true that in ischemic mitral regurgitation, the benefits of repair versus replacement is not as strong as in degenerative mitral regurgitation, where repair is definitely better compared to replacement. But in ischemic mitral regurgitation, it may be just as good to replace the mitral valve in some cases. So this is results from the RHYME trial, the randomized ischemic mitral evaluation trial, which I had the privilege of leading some years ago when I was in London. And essentially, this was a randomized trial between CABG alone versus CABG plus a mitral valve repair by an annuloplasty in patients with a moderate degree of mitral regurgitation, at ERO about 0.2, and multi-vessel, 3-vessel coronary artery disease, and with some moderate dilatation of the left ventricle and moderate impairment of the LV function. And these patients also had non-viable LV in at least 4 segments, typically in the inferior posterior segments of the LV. And they had tethering, but the tethering was not severely tethered. We consider tethering to be very severe if it's greater than 10 millimeter. So in this study, the tethering distance was 7.7 millimeter in the patients. And in this study, we did demonstrate a significant benefit with adding mitral valve repair surgery to CABG in terms of their improvement in functional capacity as measured by peak oxygen consumption, where those who had the valve repair in addition to CABG demonstrated a 22% improvement in peak oxygen consumption compared to those who had CABG, who showed a non-insignificant 5% improvement. And along with this, there was greater reductions in mitral regurgitant volumes if they had the valve repair. They also had less mitral regurgitation. Most of them had no mitral regurgitation or only mild mitral regurgitation, compared to those who continued to have moderate mitral regurgitation if they just had CABG. And there was also greater reduction in LV volumes as measured by cardiac MRI in those who had the valve repair compared to those who just had CABG, and a greater reduction in NT-proBNP levels in those who had the valve repair compared to those who had CABG. And importantly, the patients who had the valve repair felt better. Most of them were in NYHA class 1 compared to those who had CABG, who remain in NYHA class 2 at 12 months. So this is another study. This is from the US moderate ischemic MR trial, which looked at exactly the same question and did the same randomization. In this study, interestingly, they did not do cardiac MRI, so we have no information on viability of the LV wall, but they did look at wall motion score index, and you can by echocardiography, and you can see that at baseline they had the akinesia of the inferior lateral wall, And at 2 years, this had improved significantly after revascularization. So this does suggest, even though they had not assessed viability, but the fact that the LV improved in wall motion, that these patients largely had viable myocardiums. And that is where our knowledge now of the importance of determining LV viability to help guide the need for intervention on the mitral valve in this patient arises. Because in this study, you can see that in patients who had CABG, all of them had moderate MR to start with, but at 2 years, only 30% of them had moderate MR. So 70% of the patients had improved their mitral regurgitation severity just with revascularization without mitral valve repair. And that is almost certainly because these patients had viable myocardium at the time of revascularization. So in this study, they did not show any difference between CABG alone or CABG plus mitral valve repair in terms of LV volumes. And so we know now that if the LV is viable in the presence of moderate ischemic MR, it's probably quite safe to leave the mitral valve alone and just to revascularize the coronary arteries. If we to put all the 3 trials, the RHYME trial is the first trial, the US trial is Smith, and there's also an Italian randomized trial on this subject. You can see that adding a mitral valve repair to CABG does not increase perioperative mortality. It did not improve survival either, but bear in mind that even when we combine all 3 trials, the studies were still not sufficiently powered to detect a difference in survival. It's because there were only 474 patients in the study. So it is still not powered for survival. But what it does show is that we do reduce the MR severity. And by that, it should translate to an improvement in at least the symptoms for the patients and quality of life, and probably also their survival in the longer term. In the case of severe mitral regurgitation, then the decision of whether we know that we have to intervene on the mitral valve, but the decision on whether to repair or replace the mitral valve, that depends on the risk factors for recurrent mitral regurgitation. So we have identified factors which would predict a recurrence of mitral regurgitation after mitral valve repair surgery. And if they have these risk factors, then it is better to replace the mitral valve rather than repair the mitral valve. Or if we want to repair the mitral valve, then we have to do some additional repair techniques besides just an endosized annuloplasty. And the predictors of recurrent mitral regurgitation following mitral annuloplasty for severe ischemic MR are these. They're divided into 2 broad categories. The tethering indices, how tethered the leaflets are, and the easiest to measure is the coaptation or the tethering distance if it is greater than 10 millimeters. And also the LV size and geometry, if the LV is dilated to more than 65 millimeters, or in the presence of LV, basal LV aneurysm, then that is a risk factor for recurrence of mitral regurgitation. So in this group of patients, it's probably better to replace the mitral valve rather than replace it. So there are various techniques to repair the mitral valve, which I won't go into. So to summarize ischemic MR, mild ischemic MR, just revascularize only, and optimal medical therapy, revascularize if appropriate, and optimal medical therapy. Moderate ischemic MR depend on the LV viability. If all LV wall segments are viable, then just coronary revascularization. If there is significant non-viable inferior LV wall segments, then repair the mitral valve as well, in addition to CABG plus optimal medical therapy. In severe ischemic mitral regurgitation, look at the tethering distance and the LV size. If it's not too severely tethered and the LV end diameter is less than 65 millimeter, then repair the mitral valve in addition to CABG and optimal medical therapy. If the tethering distance is more than 1 centimeter and the end tethering distance is end diastolic diameter is more than 65 millimeter, then replace the mitral valve plus CABG and optimal medical therapy. So take-home message: optimal management of valvular heart disease is dependent on the etiology of the disease. Primary degenerative mitral regurgitation is best treated by mitral valve repair surgery when severe. Secondary functional mitral regurgitation is best optimized on guideline-directed medical treatment before considering any surgical or device intervention. In secondary functional ischemic mitral regurgitation, coronary artery revascularization is important. In addition to guideline-directed medical treatment, mitral valve intervention is beneficial in severe ischemic mitral regurgitation or moderate ischemic mitral regurgitation in the presence of non-viable myocardium. So this is a book I wrote. I'm so interested in this subject that I have a book. If you're interested, you can read through this book. It's not too thick a book, and I think it is very readable. I'd like to thank you for participating, for joining us today. Thank you again to Novartis also for organizing this. I'm happy to take any questions if you have any. Thank you very much.